Thank you, ma'am. Thank you, audience. Thank you, Metcon team, for inviting me and giving me the chance to share the stage with the eminent speakers and experienced teachers. So I'll cut short my topic as concise as possible. Glycemic management in pregnancy. We have already, ma'am has discussed about the one step and two step approach. So I'll talk about the glycemic targets in pregnancy. This slide is very important. It compares the different guidelines all over the world. ADA recommends less than 6% of HbA1c, where it has relaxed in between 6 to 7% of HbA1c to prevent hypoglycemia. The fasting target is less than or equal to 95. The 1 hour glucose is 140. The 2 hour glucose is less than or equal to 120. The ACOG gestational HbA1c target is less than 6. Fasting is 95 or less than equal to 95. Then 1 hour is same as ADA and 2 hour is same as ADA. The pre-gestational here we have to see in ACOG is the fasting glucose should be less than or equal to between 60 to 99 is preferable, and the targets of 1 hour and 2 hour is 140 and 120. Same goes with ACE and ACE guidelines, where the HbA1c is approximately 6.5% with 95%, 95 milligram per DL of sugars for fasting, and 140 and 120 for 1 hour and 2 hour respectively. As far as NICE guideline is concerned, it's less than 6.5 for HbA1c, 96 equal to equal or less than in fasting, and 140 and it's 116 for 2 hours of post meal. The DIPSI guidelines shows, ma'am has already shared regarding DIPSI guidelines. So it's the fasting sugar should be less than or equal to 90 and 2 hours of 120. So the targets during pregnancy for women in type 1 and type 2 diabetics, we generally monitor through SMBGs. Patients are guided and taught how to use glucometers, and when they are on insulin, and frequently as SMBGs of fasting sugar, pre-meal, post-meal sugars throughout the day is advised, and they tell us, they constantly keep in touch with us. The people who are tech savvy can be in touch with us on WhatsApp, on online consultation. So we keep the goal of fasting around 70 to 95, and on the test of waking, then 1 hour and 2 hour. Generally we go for 2 hours. It's not possible for all the patient to do so many pricks throughout the day. So pre-meal, post-meal of 2 hours, we try to keep it between 100 to 120. And the patient who are in metro cities, it's possible to keep our patients on continuous glucose monitoring. So it's for both type 1 and type 2, but specifically we keep it for type 1, and the targets of fasting sugars is kept between 63 to 140. We try to keep the time in range more than 70%, and the time below the range we try to keep it less than 4%, so lesser chances of hypoglycemia, and above range we try to keep it less than 75%, to not to avoid the sugars to go above 140. So the management of diabetes during pregnancy first is covered by Dr. Firdos about the lifestyle and nutritional therapy. Both the sirs covered insulin and metformin and the pros and cons of OHAs. So as per the insulin preferences, generally basal bolus would help better sugar control, and chances of hypo and hyper is lesser with basal bolus. And now the basal insulins are also getting recommendations to be used in GDM. So we all are using Glargine and Rhizodec. We are also waiting to get the recommendation for Tresiba so that we can use and more patient with lesser, the insulins which produce lesser chances of hypoglycemia. So with the combination of metformin is mostly seen with the type 2 diabetic pregnant female, and during the management I would also want my seniors to enlighten us. It's a day-to-day practice, what is preferred by them. Swati ma'am, I would like to know, in your day-to-day practice, do you keep your patients on CGM or SMBGs are most frequently?
Yeah, so that's a very interesting question, because SMBG is one very important aspect of management of monitoring of gestational diabetes, is very important. CGM is also very good. That can also be very well used. So both of them are used. Yes, most of my patients prefer SMBG, and they do it very systematically.
It's also cost effective.
As they know it's only for these particular months, they do it very systematically and very judiciously.
Agreed.
Afterwards, in the other patients, it's not the
Agreed,
case.
agreed. So as a pregnant female, whatever we guide them, they are ready to do, be it be 4 times insulin, be it be 7 times a day prick and inform us, they are ready to do. So it's individualization, that is the key for every patient. More the insulin resistance, more are the chances that we have to keep them in the loop more frequently. But on an average, ideally, thrice a week, 7 days, 7 pricks a day gives a very good monitoring helps us to get their sugars in target, keep in target, and prevent complications which are related to the hypos and hypers during pregnancy.
Thank
Yes,
you very much, Dr. Heena. This was very important monitoring and regulation of sugars that you mentioned. I think because we are falling short of time, we can invite
Dr.
one or two
Firdos.
questions from the audience before
Dr.
we.
Firdos. The
Okay,
postpartum.
I think so they are already short of time. So
Thank you. Thank you.
So with that, there are a large number of controversies, but some consensus statements also going on, which makes JDM difficult. But then we have to try our best. It has to be tailored as per the patient and as per the clinicians. Thank you very much.